The Congress is really fantastic because regardless of whether you're watching online or whether you're live in person, many of the really good events are being recorded. That's great because you can watch them later when it's convenient. You can stop and pause and look at the references and do all that little detailed fact checking that isn't possible when a speaker is live. But the second thing is obviously that you get to meet people, you get to unpick what's going on, what's the story behind the data, and that's always very interesting. So meeting people, that's great, but also taking the time to be able to reflect on what their talks are. For me, one of the highlights was how there were many sessions that were really indicating some innovative approaches to the management of patients with COPD that I think are practical and could easily be implemented into clinical care right around the world. The first message that really came across to me was the prognosis for patients with COPD. Kiki Wagen and colleagues from the Netherlands looked at 82,000 people who first had an exacerbation of COPD. She looked at their 5-year survival. It was really low. 64% of the patients had passed away in the subsequent 5 years. What was really interesting though was not that COPD was the cause of their death, but in fact most died of some other condition. And these were the comorbidities of COPD. So I suppose the take-home message here is that when somebody's admitted to hospital, even with their first exacerbation of COPD, this is a really big red flag for subsequent bad outcomes. The second is you need to assess the patient as a whole patient, not just as an exacerbation of COPD. Just on the line of comorbidity, a paper that really caught my eye of interest was by Van Molen and colleagues. They looked at a cardiac MRI in patients with COPD during an exacerbation. In particular, venous return was affected by hyperinflation, contractility was affected, and of course that led to reduced cardiac output. So it's a sort of double hit. The hyperinflation of an exacerbation is reducing heart function, which is of course impairing exercise capacity. So really it turns our attention to the double hit of COPD as a multimorbid condition. What's kind of interesting is that treating with bronchodilators, that hyperinflation improves cardiac function. So that's a factor that you need to think about when you're treating patients with COPD. And a really nice overview by Mei-Lan Han on assessment of COPD comorbidities. She emphasized the importance of doing CT scan at the very minimum, not least to assess if there are nodules present as a comorbidity, but also to look at how much emphysema regionally for the potential of inserting valves in patients. She also emphasized how important it was to properly assess cardiac function, such as with echo, BNP, and an MRI. And I really endorse this. I think it was an excellent review of what might need to be done for patients who have COPD who present for the first time. In a practical study, John Steer and colleagues from Newcastle identified that if you run a systematic cardiac assessment on patients, you can identify comorbidity of cardiac disease in about 50% of them. And addressing this reduces subsequent admission. I think that really shows that even at a most practical level, we can all improve our outcomes for patients with COPD by looking at the heart. Unfortunately, in some patients with COPD, we have to address the inevitable, which is palliative care. And that particular topic was addressed by Joanna Broese and her colleagues in a really nice randomized cluster trial. What she did was give a toolkit of conversation and suggestions and materials that primary care physicians and hospital physicians could use as they discuss palliative needs with patients with COPD. And what they found was there was no reduction in the quality of life of the patients who were randomized to have a palliative care conversation. But there was a significant reduction in the number of people who were being admitted to the ICU. In other words, they had taken on board the palliative conversation and decided not to escalate treatment when their condition deteriorated. There was also a trend towards a reduction in admissions generally, indicating that people were taking the option to maybe receive palliative care at home rather than in hospital. This is a really interesting study, a very thought-provoking one, and I think it's one that we can easily incorporate into practice. On the subject of palliative care, Ferreira and colleagues in Australia reported on a randomized trial where they gave 2 doses of a slow-release morphine and compared the effect of these medicines in comparison to a placebo on breathlessness in patients with advanced COPD. This study was really provoking and interesting and probably adds to the literature, which showed that whilst breathlessness was somewhat reduced, the side effects were significant and the overall benefits were very trivial, and really strongly suggests that a very delicate approach at a very personalised level be adopted in terms of using morphine to relieve breathlessness in patients with advanced COPD. So not a great therapeutic advance forward, but sometimes knowing what not to do is just as important as what to do. In terms of active treatment of patients with COPD, we'll all be aware that there is an emerging story about whether we should or shouldn't use corticosteroids in exacerbations. It's really quite surprising that the total number of patients enrolled in randomized trials looking at the effectiveness of these treatments amounts to no more than 1,000 patients. My hospital alone has 1,000 admissions a year of COPD. This illustrates the scale of how under-researched this really common condition is. Mona Bafadil and her colleagues performed a really nice randomized trial, which I'll bring your attention to, which was at the alert session. In this trial, she looked at the effect of using a point-of-care eosinophil test to see if personalizing steroids only to patients who have elevated steroids is more beneficial or less inferior in terms of rate of relapse compared with placebo. Patients were randomized to receive corticosteroids in the active group only if they had elevated eosinophils on the point-of-care test. In the control group, all patients got corticosteroids. So the primary endpoint was a non-inferiority. In other words, if patients who didn't get steroids because they didn't have elevated eosinophils, were they more likely to be admitted to hospital, represent to the GP and get steroids or antibiotics at 30 days.
The intention to treat analysis demonstrated that there was no difference in the number of treatment failures between the blood eosinophil directed care arm and the standard care arm. In fact, this would tell us that the study, when we powered it, showed it was non-inferior in terms of this process. In the per-protocol analysis, it also demonstrated that there was a suggestion that there was possible superiority of using a blood eosinophil-directed oral corticosteroid prescriptions at the time of an acute exacerbation using the point-of-care eosinophil test.
Patients who had steroids only prescribed when there was elevated eosinophils did as well as all the patients who got corticosteroids. So, what I would take home from this is, if the eosinophil count isn't elevated, you should not give corticosteroids because of the long-term side effects of these medicines. And repeated courses of steroids don't look like much, but cumulatively they become a big problem. So again, something to bear in mind in our treatment. It's as important not to be over-treating as much as it is to be under-treating. In support of this work, there was a really nice paper by Helou and colleagues from Birmingham. It's a really simple project, but what they did was develop an electronic alert system on their electronic patient record that if a patient had been prescribed both a nebulizer and steroids when they were admitted, an electronic note was sent to a healthcare professional on the respiratory team, who then went and assessed the patients. Over a very short period of time, they had about 100 admissions, and 50% of them had a down escalation of the corticosteroids when a member of the respiratory team assessed all the suitabilities for steroids. So I think this is a very simple take-home message. De-escalating is likely to reduce the comorbidities of corticosteroids, such as diabetes and the long-term risks like osteoporosis and bone thinning and so on. So I think it's a really interesting and, again, practical project which illustrates how you can implement clinical trial research into practice and get really good outcomes very quickly. Unfortunately, some patients with COPD deteriorate, and Paolo Naveza gave a really fantastic talk about high-flow nasal oxygen. Now, this modality has come in the last few years, and he gave a really clear talk outlining where we should be positioning this. I suppose the take-home message is, if you have mild to moderate COPD exacerbations with hypercapnia and acidosis, this therapy is an alternative to non-invasive ventilation, but there's a lot of relapse. So I think the take-home message is always use NIV first in hypercapnic acidotic respiratory failure patients. But if they need a break, if there's just time away from the NIV because they're feeling claustrophobic or because they need to ambulate, high-flow nasal oxygen is a really superb bridge and highly recommended. Paolo also indicated the high-flow nasal oxygen could be used as an alternative for patients who have severe hypoxic respiratory failure from community-acquired pneumonia or other causes of hypoxia. And again, he's illustrated how effective it can be either in bridging ICU or as an alternative to NIV in patients who have non-acidotic hypercapnic respiratory failure. It's a really elegant talk, positions that new modality very nicely. Marieke Duiverman also gave a really excellent talk outlining the role of NIV in patients with COPD. She made some practical observations which I think are well worth considering. She talked about how NIV is often considered rather negatively by physicians who are managing patients with hypercapnic respiratory failure.
Yeah, there's really tough evidence that NIV is beneficial in patients with acute exacerbations and hypercapnic respiratory failure. But we also know that there's large variance in how people are using it between hospitals and also between places. But what is also important to realize that it depends on facilities of your hospital and how people are educated, whether you have protocols to attach to. And we also see that there is still some sort of doctor's pessimism in this, that doctors believe that it might not be beneficial in these severely ill patients, but it is. And there has been a study showing that when you ask doctors, what do you think about the prognosis of patients, that they think that less than half of the people would survive after 180 days. But in fact, it was over 60%. So that's a large gap, and that represents a pessimism that we actually don't want.
She really exerted the idea that we should be positive about it because the outcomes are so good, and I concur. And she also talked about the practical need of having a good management strategy. But most of all, I took home a great and simple message. Use whatever modality you feel comfortable with. Don't necessarily feel that one strategy is better than any other. I thought that was a really great presentation and a really reassuring take-home message.
And I think the most important thing for a hospital is that they should use a ventilator with which they have experience, but also the masks to use, the place where you should apply NIV. We also know that a lot of disturbance is, for example, not beneficial for patients. And if you don't have experience with it, you can talk with your intensive care doctors, they have a lot of experience, or go visit other hospitals to see how they apply this therapy.
Most of our patients are treated with inhalers, and Omar Osmani gave a great talk on the evolution of inhalers. He made some really interesting points. The devices can be simple. If patients can't use them, there's no point in prescribing them, but that there's an awful lot of new technologies that are picking up on how effectively patients can use their inhaler. And he outlined how many new devices are in preparation, particularly digitally enabled ones that will give feedback to the patient on how effectively they've used their treatment. Some of the key messages that I thought are worth remembering at top level is that when a patient with COPD is admitted to hospital, that's a red flag. One of the messages that also struck me was that comorbidity is really important in patients with COPD. So we need to look at things like their cardiac function. There's also the prognosis piece. How do we manage the fact that we need to address palliative care, and what strategies are available to us? Of course, with any clinical condition, it's as important what you don't prescribe as what you do prescribe, and some really interesting features about that. And of course then, what's in the future? And there's lots of interesting things coming down the line. They're quite early, but they look quite promising.